I work both in the private and the public sectors. So within private obstetrics, you'll find obstetricians. Most people will book with an obstetrician who work either in the public and the private sectors, or entirely in the private sectors. And those who work within the public and private sectors will often deliver babies at their own hospitals, whether that be St Thomas's, which I'll tell you a little bit about today, or Mary's, or UCL, or the Chelsea and Westminster, or Charlotte's, and the major ones. And when I was thinking about what to talk to people about on a Sunday morning, when the weather was predicted to be particularly nice, I thought I'd try and give you a general chat about life at St Thomas's and why you might choose to go to a hospital with all the bells and whistles rather than perhaps the brass buttons and champagne. St Thomas's is a really old hospital. It dates back to the times of King Henry VIII. In fact, the site in Westminster is where St Thomas's moved to when it separated from the Guy's Hospital, which is at London Bridge. And in fact, where London Bridge Station is now, it used to be the old St Thomas's. And Guy's Hospital at that time was funded for the very poor people. And the rich people at St Thomas's moved to this site. We have a long heritage of looking after mothers and babies. This is what one of our wards used to look like a number of years ago. The nurses are no longer dressed like that, and neither are the midwives, but the surroundings probably haven't changed for many years. They used to take a lot of the children out and the babies out into the sunshine, something to do with vitamin D and keeping them free of rickets in the time when the people lived in the inner cities in the darkness. The views haven't changed dramatically, and this, I have to say, is one of my favourite views. And actually, I get the same view of this from my office. We never get sick of looking at the river and looking at Big Ben. For those of you who know where Big Ben is, and I suspect all of you do, if you sort of turn round and gaze at the big wheel and County Hall, and look slightly to your right across the river, you'll see St Thomas's Hospital. You can see the bit over on the right-hand side is the old hospital, and the bit on the left is obviously the new hospital, and it looks really big. You often want sort of something that's a bit cuddly and soft and small and when you go into a hospital. A lot of people who come to Thomas's said they see sick people and they see all sorts of things that they didn't really want to see. They'd like to see something a little bit more, a little smaller and more inviting. And the reason it's big is that there's a huge amount in St Thomas's, and I'll try and tell you a little bit about it. As you get closer, you can see that we actually have some bit of greenery around St Thomas's, and I took these photographs last weekend on a particularly nice day. And you can see the fountain, the places that the staff and the visitors and some of the patients go to enjoy a little bit of downtime. And actually, I think this looks particularly inviting. I did find that this picture that I took probably doesn't look quite so inviting. This is just before the entrance, but I think that's probably something to do with the camera angle rather than the statues themselves. St Thomas's itself is big, but alongside St Thomas's is this building. This is the Evelina Children's Hospital, a fantastic building and a fantastic paediatric hospital, and one of the biggest in Europe, and one of the best, I think, in London. And if wherever you have your baby and you have a sick child for any reason, I'd take the child straight to the paediatric emergency department at St Thomas's. Absolutely fabulous. I used it for our children, and I have to say I couldn't have bettered it even in the private sector, to be honest. We have a car park. We have a huge car park. So one of the things that is always difficult if you're going to anywhere in central London, particularly if you're racing there in the middle of the night to get to the maternity ward on time, is having somewhere sensible to park. In fact, it's such a good car park that a lot of people use it for many years after they've had their baby to park their car on their way into the city, where they can get on the tube just at the other side of Westminster Bridge. Within the big St Thomas's, we have our oasis of calm, which is the Westminster Maternity Suite, where you will be staying after you've had your baby. I think the way to look at St Thomas's or any of these big hospitals is that you're signing up to a part of a team. the facilities at these hospitals, and when we were designing our model of what we would want and what we thought would be good maternity care on the private side, is that we wanted to get all the bells and whistles, all the gadgetry, all the expertise, all the very high-tech equipment of the NHS, and offer them in exactly the same way to our private patients. And what I often say to people is that you're almost going onto an aeroplane, but you're turning left and you're walking right to the very front, and you're being guided by the person who's probably going to fly you on that aeroplane. You'll still get there if you turn right and go to the back, but you'll just get there in a very different and a much more comfortable way. We have a very nice team up on the Westminster unit from our receptionists onwards. The views, this is the view that you get from your room on the Westminster maternity unit. And I think views do aid recovery, to be honest. They certainly distract you from crying babies and those sort of things in the early time of your stay. And for those fathers who need to go and have a large brandy and perhaps smoke a cigar, there's a little outside courtyard, which would be much nicer when the flowers start to show. You can gaze up at the stars and think, what have I done? Being that it's a team, and being it's a big hospital, you'll come into contact with midwives. And people often, when they come and see me, say, when will I meet my midwife? And actually, you try and point out to them that actually they've booked under an obstetrician, and the midwife who will be looking after them will be one taken from the pool of midwives that we have in the Westminster unit, or those that we have on our delivery suite. And the good thing about this team is that they're used to looking after healthy people as well as sick people. The expertise and skill level amongst these ladies is phenomenal. We have a big team of doctors. One of the things you hopefully will never happen to you is that if somebody pushes an emergency button whilst you're in labour or in the hospital, you'll have a whole throng of people running to assist you. It was 8 the last time I pushed the button. And that's the sort of staffing levels that you need to deal with things that you hope you'll never encounter, such as obstetric emergencies. We have a garden room. So when you're in the early stages of labour, it's quite nice to go and have somewhere to stroll. You're not allowed to go out into the grill garden when you're in established labour, but we tried to create a garden room, and from that garden room, which has, these are not real flowers, unfortunately, and the same sort of views that you get from your room upstairs. Tommies is a very friendly place. It's a very big place, but we're very patient-focused and patient-centric. This is one of our porters, actually a really nice chap, if you get to meet him, who is one of our figures for the Putting Patients First initiative that was put out from St Thomas's. I think we have huge heritage in all the things that you would expect. I think when you go to have a baby, there are certain things that you would expect, and you've heard talks from people. If you came yesterday, you'll have heard about fetal medicine, you'll have heard about what to expect from an obstetrician, what perhaps to expect from a midwife. And for those of you who arrived early, I think there's just been a talk on having a cesarean section. And I think when you're booking with a private obstetrician, I think you can assume that all those things are standard. Those are the things that you would expect the person who's looking after you to be very good at. And a lot of people will book with an obstetrician, not because they necessarily want that obstetrician to do their normal delivery, although that's what we do, but because when you're confronted with an emergency, the last thing you really want to meet for the very first time is the person you don't know. And one of the things I really like about doing private obstetrics is that although sometimes it's far more complicated, you actually get to look after people the way that they'd like to be looked after and the way you'd like to be looked after yourself. And maybe some people who have a very straightforward time, that never really delve into the skills of their obstetrician, perhaps feel a little bit cheated because they really haven't necessarily got value for money. But I always tell them they're the lucky ones and just think what could have happened. I was in the position recently of buying a car for my 21-year-old son. He's just passed his driving test, so be careful on the roads. And when I was looking to buy him a car, I was looking at slightly different types of cars to those that he had in mind. He was thinking of a V8 Mustang. But the thing that struck me is that there was a certain level of car I was going to buy him, and all cars have 4 wheels, and they all do far too much nowadays. But the thing that really interested me was the number of airbags and safety features. And immediately, obviously, I started looking at a Volvo. Volvo with effortless safety. And I think effortless safety and being prepared for the unexpected is what I'd want with my very precious son, cocooned in a piece of metal. And actually, in many ways, that's the same way that I would approach obstetrics. And we hope it's all very straightforward, we hope that it's all very nice, but it's not always so. And when the unexpected happens, you want to be somewhere that can provide everything that you could possibly need to make things right again. Tommies is a very big place, and there's lots of different services. And what I will do is just take you through some of them. If there's any that I miss off, I went through talking to my wife, and she pointed out one which will become immediately obvious to you later on. Then we'll have plenty of time to discuss at the end. This is my colleague Dharmindra, lovely chap who's a fetal medicine doctor. Patients, when they may have had their scans with Professor Gynaecologist, who I also use, and it's fantastic at the Fetal Medicine Centre, may well have complicated pregnancies needing much more closer surveillance within the hospital. We have a fabulous fetal medicine service, as you'd expect from a level 3 hospital. Not only competent in the sort of prenatal diagnostic testing and scanning and screening that you've been hearing about, but also the more complex following up of pregnancies that are complicated perhaps by growth restriction or unexpected abnormalities that require continuous assessment. Twins, higher order pregnancies, triplets, those sort of things, again, would require the specialist facilities of a fetal medicine unit. Our fetal medicine unit, however, has access to an MRI scanner as well. There's an awful lot of MRI work now going on to see in far greater detail many of those things that you can't see on an ultrasound. We're looking at brain development particularly and cardiac abnormalities with MRI scanning. And this isn't two sets of twins that happen to be very good friends. This is the same set of twins, just looking at the movement pattern of them somewhat differently. One of the big problems with things like MRI scanning is that it's actually quite difficult to do an MRI images while somebody's moving. And a lot of this work on fetal movement with MRI scanning has allowed us to do dynamic MRI scanning on adults also. When you're having a baby, a lot of people never really think about the baby. And actually, from a pregnancy perspective, it's far more likely that the baby will get unwell than the mother. I haven't seen any neonatologists coming to talk at these sort of meetings, but actually we're treating 2 patients rather than 1. And the small one has a far greater chance of needing medical care than the big one. This is our neonatal unit, and it's part of the Evelina Children's Hospital. And if you do find that you need to go to the Evelina Children's Hospital, both your baby and yourselves will need the attention of people such as these. We have a fantastic consultant-delivered neonatal service. I have to say, I think it's probably second to none. And they had a fantastic rating with the CQC recently that paediatric and children's services were designated as outstanding, which is an achievement that's actually really very difficult to get in a big teaching hospital in central London, when there's so many things that are potential to go wrong. Our unit takes tertiary level care. We take babies and have good outcomes for babies from about 23 weeks, although we take all gestations. But 23 weeks is the smallest that you'd particularly like a baby to be to go into a special care unit. And most units will take them from 28, or some of the purely private units from 32 weeks. But we do see babies of this sort of size. The unit has everything that you probably would expect and more. It's probably one of the best equipped units in the United Kingdom. And things like intensive care, both for adults and children, are really, really expensive to run. The model of trying to set up an intensive care unit or a very, very high-tech special care unit within the private sector is difficult, because to make it pay, you'd have to have these beds occupied all of the time, which doesn't happen. So you need, from a baby's perspective, to be somewhere within the aegis of a big teaching hospital. The MRI, not all babies are born neurologically normal for whatever reason, and we're now understanding an awful lot more with MRI imaging of the brain, the various different pathways within the fetal brain that can be abnormal in ways in which we can improve brain development for babies who have been unfortunate enough to suffer some sort of brain injury. And we receive patients from all over the southeast into our neonatal unit, partly because we have the huge Evelina Children's Hospital, where a lot of the cardiac surgery, the neurological surgery, the brain surgery, everything that's complex that you could possibly imagine from a child will come. This is the sort of setup you'd see in a neonatal unit. We have obviously high-level neonatal intensive care and special care designated as a sort of step-down area, and probably equivalent to what most other types of units would provide as their baseline. The Evelina Children's Hospital, a fantastic building where pretty much any surgical or medical facility that your child could need, either around the time of delivery or after, is available. And we have a lot of very complex types of cases. And we're one of the, well, in fact, from a cardiac perspective, my wife's a cardiac anaesthetist working at the Brompton. But a lot of the more complex cardiac cases now are coming to St Thomas's, because we're the only place within London that you can deliver a baby and operate on its heart within the same institution. And we're getting increasingly busy from those sorts of things. From a mother's perspective, if I was having a baby personally, I'd want to be in a place that is comfortable but safe. Not everybody is well, and a lot of the sickness becomes somewhat unexpectedly. And within the centre of our delivery suite, we have what's called a high dependency unit, which is like an intensive care unit for people who had major hemorrhage, or people who have other complex types of medical problems, such as preeclampsia. And a lot of these things are not predictable when you're booking. A lot of them occur to healthy people as well as unhealthy people. And what you want are the facilities on site to be able to deal with them. I didn't used to do the vast majority of my private obstetrics at St Thomas's. And I remember delivering at one hospital once, and we were having difficulty with a postpartum hemorrhage, which is when people bleed after the baby's born. And we just couldn't get enough blood to this hospital because it didn't have on-site blood transfusion and on-site haematologists. And so we had to go in an ambulance to when we were then based at Guy's Hospital before the rebuild. And one of the things that places don't necessarily have in the smaller hospitals is things like interventional radiology. You get to the state with major hemorrhage when you need not only to replace product but stop the bleeding in some way. And you've tried all the simple obstetric things, and then you're faced with the, do I do a hysterectomy to remove the uterus, or do I do something else? And one of the things we use a lot when we get people coming in from outside, although ideally if you've got sick people, you want to have the sick people on site and never transfer a sick person. Things like interventional radiology, when you can block blood vessels under CT guidance and actually avoid doing big surgery like hysterectomies for people who've just had a baby. But that's the sort of level that you'll get at somewhere like St Thomas's, or indeed at maybe Chelsea or at Mary's, but things that you would want. And when I was talking to my wife and telling her about all the things that I thought people would find important and find necessary, she said, "You've forgotten Wi-Fi." Well, we have free Wi-Fi at St Thomas's as well. Have any of you heard of Tommies the Baby Charity? Well, Tommies the Baby Charity was actually set up by my two previous colleagues. In fact, I used to be a trustee on the Tommies Baby Charity. And essentially what happened is there were a number of very wealthy people who had had complicated pregnancies, and they felt that they needed to give something back. They're very well known now, and the charities that they started was Tommies. And the two initial founders of the Tommies charity, one of them had a problem with a stillbirth, and one of them had a problem with prematurity. And they set up a charity under the aegis of two obstetricians, Ian Ferguson and Anthony Kenny, who set up who used to run the private obstetrics at St Thomas's, to raise money for these two causes. And obviously Tommies has now become a very, very big charity, and no longer can we do the sponsored swim or the annual dinner to raise money, because this charity is raising millions. But putting that money back not just into Tommies now, but into creating chairs and research departments around the country. I have to say one of the big unsung heroes of St Thomas's in my mind is this gentleman, the slightly balder gentleman in the middle, who is a chap called Professor Shannon, Andy Shannon. He and I are the same age, believe it or not, although I seem to hold on to my hair. Maybe it's being an academic that's very stressful. And these are the sort of people that you need access to when you're having a baby. He doesn't do private obstetrics. He's far too busy thinking, which is what obstetricians, what academics tend to do. He runs a big research team. But the things that they do and the things that they provide should be just as accessible to private patients as to public patients. From a hypertension perspective, and that's one of his major focuses of interest, it's a cause of stillbirth and prematurity. He's developed a very interesting gadget recently, which is now featuring in the Science Museum, which costs £12. It's actually one of the Bill and Melinda Gates Foundation grants. And is rolling out a big study in Africa at the present time, looking at whether this simple device, which we're going to be starting perhaps to give to mothers who will take their own blood pressure, all of us can afford £12 to monitor something that can change quite precipitously and abruptly. This sort of gadget makes a big difference in other parts of the world as well as to us. To the very complex side of hypertension to preeclampsia, this new test that's just recently been approved by NICE, which allows you to measure the function of the placenta on a simple bedside test to tell you whether your bit of blood pressure is preeclampsia, which is a very serious condition, or perhaps hypertension that can be treated in other ways. In terms of prematurity, they have one of the biggest preterm surveillance clinics in Europe, run by Andy, which scans people and looks at the length of the cervix, a very good predictor, but also they've introduced various other tests. And the very simple test that they've introduced, which featured in the Telegraph when it came out, is something called a fetal fibronectin test, a simple swab that you can take from the vagina, measure the level of fetal fibronectin, which gives you a very good predictor, along with cervical length assessment and history, as to whether you're going to deliver prematurely or not. They've developed an app, which is now available, that you can use with these measurements, and that app will allow you to predict, on the basis of these very simple measurements, your probability of delivering early. Now, this has relevance for various different groups. For a lot of my private patients, it allows them to know whether they can go on holiday. They can have this test done. They can say your chances of delivering prematurely are very, very small, and they will get on that long-haul flight and have the holiday that they'd planned. It's called a baby moon or something, I think, isn't it now? To the patients who come into hospital with pain, who we don't know whether this pain is indicative of the fact that they're going to deliver early, but these simple tests will be able to tell us. And the prematurity service and the prematurity clinic we use a lot, and it's available to the public and the private patients. I've got permission from the mother of both of the babies I'm going to show you, because I'll show you a couple of stories of why I think somewhere like St Thomas's has been so good. And this is Baby Hope. Baby Hope's mother was one of my private patients, fit and healthy like all the ladies that I can see in this room. And at about 22 weeks, she came into hospital with pain. And we did our tests, and our tests suggested that she was going to deliver very early. And she stayed in hospital and went into labour despite everything that we could do. And it gave us good prediction of things we could do, like giving steroids and giving magnesium, which make a huge, huge difference to the survival of premature babies. But Baby Hope was born at 520 grams at 20 weeks. All the things that I've just showed you, our special care unit, babies like this would not survive under normal circumstances at other types of hospitals. But this one survived. This one survived, and survived very well. And this is a message that I got from Colette, or Andy and myself got from Colette, telling us about the survival of their child and the fact that actually she's normal and will live a completely normal and happy life. This is another of our successes. We have a lot of successes, but let's just concentrate on these two. And this is baby Amelia. Now, Amelia's mother had a condition called severe preeclampsia. And in these sort of cases, you're often faced with the decision of when to deliver. That causes very severe growth restriction in severe cases. And as a life-saving procedure for the mother, you often sometimes end up delivering the baby somewhat prematurely. This is Amelia at 2 weeks of age and barely bigger than the teddy bear. 7 years down the line, this is what Amelia looks like. And you can see the teddy bear at her feet. I think a bear that she'll probably hold on to for many years. That's Tommies in a nutshell. Obstetrics is really happy the majority of the time. But when it goes wrong, it can go very rapidly wrong. And you want to put yourself in a position and a place that actually you can be looked after. But don't forget just yourself. And a lot of people, and a lot of us, I guess, are quite selfish. It's all about our experience. And the experience, perhaps, that you may be wanting to think of a little bit more is perhaps the boy that you're going to call Ben. We have so many Bens or Thomases. And maybe we need to give ourselves a bit of a girl's name as well. And thank you for listening. That was the view from the delivery suite around the time of the Olympics. They used to project onto the side of the Houses of Parliament and made a great screen. Thank you very much. We can take any questions you want. You can ask me anything, and we've got about 15 minutes, I believe. Is that right, Neve?
That's right, yeah.
Okay. They said to stick to... You don't have to ask any questions because it is a great day outside, and St James's Park is a very short walk away.
Thank you very much, Con. That's great. Yep, go ahead.
Hello, you hear me?
I'm
just wondering, when people are making decisions about where to go, how do you balance, or how do you recommend balancing between choosing the hospital and choosing the obstetrician?
Choosing the hospital. Choosing the obstetrician, I think, to be honest, the vast majority of people who do private obstetrics are good. What do you need to do to be good? You need to be able to be nice to people. You need to be conscientious. You need to care. You need to want to look after people the way you'd want to be looked after yourself. Most people should be able to do all the surgical procedures, all the interventional procedures, and I think, by and large, the people who are doing private obstetrics are good. I can't think of any of my colleagues that I wouldn't let my daughter be delivered by. Where to deliver, I think, is really complicated because you get blinded by various things. Private obstetrics is really expensive. It's expensive because it involves a lot of insurance the obstetricians pay, but it's expensive. And all the people, predominantly all the people, some who aren't entitled to NHS care, have already paid. They've paid for their NHS care. So they're paying for something special and different. Inevitably, they're going to be richer people. And actually, all the people who are in here will know lots of very smart restaurants in London where they would like to go and eat. Everybody can afford a good hotel. They can afford good food. So I would accept mediocre food and I would accept hotel facilities that are adequate. But I'd go somewhere that's safe. Do you know, safety in medicine, if you've ever been on the cutting edge of unpredictable things not going wrong, but just being nature, you want to be somewhere that's safe. And I will definitely pay for my daughter to have private obstetric care because I want somebody to lose sleep if she's in trouble. But I'll pay for her to go as long as she goes to a proper hospital because the facilities that you have at proper hospitals for dealing with sick people are much better. So how would you choose your hospital? Obviously I'm biased, I'd choose Thomas's, but if I was pushed to say, is there nowhere else in London, because I really don't like Thomas's, then Mary's, UCL, Chelsea, Westminster. would be my choices.
Con, just on that, you know, for people, because as you mentioned, it is obviously very expensive if you're going to go for the whole package. Is there any kind of payment program, or do you have to pay the full amount up front? How does it generally work?
It is expensive. I suspect there are payment programs, and there's payment programs in everything that you can always borrow money. I found my daughter was borrowing money, and she's borrowed quite a lot of money, which we've had to solve. So there's lots of ways of generating income. I would look at the costs, the relative costs of Thomas's. Thomas's is cheap compared to lots of other places. So I think we're very cost competitive. You know, for the vast majority of people, I don't think cost necessarily comes into it. I think that people look at it and think, I can't afford that, or look at it and think, yeah, I can afford that, I hope it's worth it. So I think you have a very select group of people. I always used to sort of equate private obstetrics with school fees. You know, term school fees at Wickham Abbey is about the same as having a baby privately, and you'll pay that 3 times a year. So the vast majority of people who are looking down the private obstetric route can afford it. And should you take out huge loans and stretch yourselves? No, I don't. You should. I think that I know I work in the NHS as well as the private sector, and I have to say I would give very good care. And if you take my analogy of the aeroplane, I have to say I'm maybe fortunate now that I can turn left when I get on the aeroplane, but I know I'll send my children right. They'll complain bitterly, and they'll get there at the same time as I do. And I think maybe that's the sort of equation you should look at. All the things and all the bits and everything that I've told you, and every single one of the colleagues that I have at St Thomas's work in the NHS. We look after the sick people. And so I think our NHS service is fantastic. If you wanted individualised service, then pay for it. And I think it's worthwhile, because I just think that personal focus and that personal caring, and somebody who does lose sleep about it if you're poorly. You know, when they go home at the end of the day, it's not clock on, clock off and shift systems. You take the problems home with you. You worry, you check. And actually, within big organisations, that's something that's not being checked by an individual. It's being checked by a team of people. And that's why I think private obstetrics is good. But no, if you're doing the maths and the maths don't add up, go down the NHS. It's fabulous in a proper hospital.
Any other questions? I've got a few more. In terms of maybe selecting, you know, obviously for those that have been here all weekend, we've heard of private cesareans, private scanning, maybe choosing a private midwife, which we're going to hear next, choosing a private obstetrician. I'm going to put you in the corner now and say, if there was one of those that you could pick, you know, if you could only afford maybe one element of that private care, could you maybe tell us what element is important?
Yeah, I'd pick a private obstetrician. Now, the things you worry about are not the pushing out a baby. What you're worried about is the things that become more complicated. If you book a private midwife, they'll look after you beautifully. And we have midwives that look after people as well, but they would come as part of your package at somewhere like St Thomas's. The thing that I always find slightly unsettling in the NHS is that you've never met somebody before. They've been going through a nice, normal, natural process, and all of a sudden you wander in and you give them bad news. In the public sector, we come in and do things to people. I'm going to do a cesarean section for you. Okay, thank you. Or your baby needs to come out now, the heart rate's gone down, I'm going to do a forceps or a von twos. And you've never met these people before. And I think you give up a huge amount of autonomy if you're a patient. I was a patient in January. I had my nose operated on, which became something that I could breathe through now rather than just balancing spectacles on. But you give up a huge amount of autonomy. And actually the thing that, and I was, maybe it's because I'm a doctor and we're a bit controlling, the importance of selecting the person who was going to do this operation to me when I was asleep became overwhelmingly important. And equally, if I'm going to have an operation, even if I'm awake, I want to know who's doing it. I want to feel comfortable that they're nice, that they understand me. And that's private obstetrics. So what would I choose? The best part is continuity, private obstetrics. And I'd go for the whole package. And if you can't afford the whole package, the vast majority of the package is the delivery anyway. And actually the antenatal care is not expensive in the great scheme of things. And actually, if you just go for the very end, you haven't got the continuity. You haven't built up a relationship. You don't know the person as well. It's when you have, if you look at figures for, say, for caesarean section, so somewhere like St Thomas's or Chelsea or Mary's, about 30% of people will have a caesarean section. So you've got a 3 in 10 chance of having an operation when you have your baby. And actually, I'd want to know who's doing it. I'd want to have an anaesthetist. It's maybe not the biggest scar you're going to have, but I want to know that they're good at doing it. I want to know it's straight. I don't want anybody practicing on me. Now, obviously, I've practiced on people when I was a junior doctor, but I know I'm better now than I was when I was a junior doctor. And people who go down the private route have the option of choosing.
And if you're under somebody like your care, or you've been with the same obstetrician, say for the whole 6-9 months, whatever it may be, and you go into spontaneous labour, we spoke about this in the last session, and you come in, I mean, will I be guaranteed that I will see the obstetrician that I've been dealing with? What happens in a situation like that?
Pretty much, to be honest, Niamh. So when we're booking, we book responsibly. So we book only the certain number of people that we can actually physically look after. All of us have holidays. Over holiday times, we tend not to book anybody, usually from weeks before to weeks after, depending on how long away you're going to be. We all have cross cover, so you have to be 100% available. There is nobody else that's going to look after you. So I work with a colleague of mine called Dharmintra. And so Dharmintra is actually covering me at this moment. And when I finish, I'll phone him back and say, Dharmintra, I've now finished lecturing. Because you have to have your phone turned off when you're giving a talk. So, but it's that sort of level of cover. It's a slightly odd life in a way. You know, I used to get bought lots of wine. So always buy your obstetrician wine. And I don't know when patients thought I could drink it, because I'd either have to be in a state of permanent alcoholic stupor to get through all the wine, or else I'd have to be storing it away somewhere. I had to buy a cellar to put all the wine in. But I do have a very good wine collection, but it's a slightly odd life. You're the most unreliable person to everybody other than your patients. I've been so many times to see Les Miserables and still have not seen it, because I always get called away. So actually my wife asked me to book something, and I booked nothing. We try very hard not to go out. To go away, you have to go away. It's great to get on an aeroplane, and I get drunk within seconds.
Would anyone else like to ask another question? Don't be shy.
Hi, good morning. What is your view on elective caesareans? Just following on from the previous session, just to understand what you...
I think they're elective caesarean sections for 2 reasons. One is because you absolutely need one. So say you have a placenta previa or something that says you can't deliver vaginally, then you need to have a caesarean section. I think maybe what you're saying is I would like a caesarean section. Not that you personally would, but what's my view on that? One of the worst things I ever did in my obstetric career was talk my wife out of having a caesarean section 25 years ago. My daughter's 25 now. And my wife, being a doctor slightly controlling, wanted to have a planned caesarean section. And her reasons for wanting a planned caesarean section were that nobody could guarantee, in fact, nobody ever could guarantee that she would go into labour, have a very straightforward labour, which wasn't particularly painful, push a few times, baby would come out, she'd have no tearing, she wouldn't have any pain with intercourse afterwards, she wouldn't get prolapse, bladder problems, bowel problems as a consequence. She didn't want an emergency caesarean section, and she didn't want an instrumental delivery. And nobody could guarantee to her those things would happen. And of course you can't, it doesn't work like that. And therefore she wanted a caesarean section. But the evidence wasn't there at that time that pelvic floor damage was related to vaginal delivery, as opposed to being pregnant and just carrying the baby. The evidence is fairly incontrovertible now that, although it's multifactorial, it's related to childbirth, vaginal childbirth, or attempted vaginal childbirth. And so the poor bit of advice I gave her, and she had a terrible labour, poor lady, and I don't think has quite forgiven me. My life my gynaecology world is pelvic floor prolapse. So I see a lot of people in the private sector who come to see us because they've had a very difficult time in the past. Unfortunately, the delivery that causes the vast majority of the damage is the first one. 85% of the damage to the pelvic floor is related to the first delivery, and obviously it's cumulative thereafter, and therefore having had a vaginal birth and having significant pelvic floor damage, having a caesarean section to prevent the problem that's already there doesn't hold. I think that when people come and say they would like to have a planned caesarean section, my head starts whirring. I think, well, maybe if I was having a baby, which I'm not, that probably I'd want to have a planned caesarean section as well, for very selfish reasons. But I would always look at myself and think, well, would I be a good surgical candidate? And if you look at yourself and think, well, I'm slim, fit, healthy, well, and young, then actually you're a very good surgical candidate. And how many babies are you going to have? Because when you get onto your fourth or fifth caesarean section, they're getting a bit tricky. And do it at a place where it's very safe, and do it at a time that's very safe. The one downside of caesarean sections, and there are a few, and obviously it's an operation, we mustn't forget it's an operation, but from a baby perspective, taking a baby out by caesarean section increases its chance of having breathing difficulties. You can halve those difficulties by waiting from 37 to 38. You can halve them again by waiting from 38 to 39, and after 39 weeks it doesn't make a huge deal of difference. But do it at a sensible time. And don't plan to have lots of babies. I would probably plan to have 2 or 3 babies if I was having planned caesarean sections, because if you change your mind and you think that wasn't such a good idea after all, then you're a little bit stuck, because your chances of having a caesarean section, if you've already had one, particularly an elective one, are higher. And the only thing you really do deny yourself by having a planned caesarean section is that, would you have had that very straightforward vaginal delivery? And if, when you've put your list of the things I would really not like and the things that I would really like, the desirable and undesirable list, if you come out with, I'd still like a caesarean section, I think it's a good idea. I think it's choice. Do you remember, well, maybe you don't, a number of years ago the government had this initiative which was called Changing Childbirth. And it was all about giving mothers choice about where you want to go, how you want to deliver. And what they weren't expecting is that a lot of mothers would choose that they'd like to have a caesarean section. So the initiative then had to change completely, because it now sort of comes out as you can choose what you'd like, as long as we'd like you to choose it. It's difficult. Within the NHS, you have to offer the same things to everybody, and it's more expensive. The cost of doing a caesarean section, it's a lot more than taking people down the normal route. Everybody who needs a caesarean section within the NHS will get one, and they'll get it done very nicely. But as a choice, we can't offer everybody the same things as slim, fit, healthy you. If you're sitting next to somebody with major comorbidities and overweight, poor surgical candidate, we couldn't offer them surgery and think in our heart of hearts that that's safe, because it's not. It's just different. But if people wanted one and they understood that it's an operation, how it's done, then I think, yes, you allow the choice, and it's not an unsafe choice.
Thank you.
Hi. One of the appeals, I guess, of the private ward is to remove yourself from some of the stresses and constraints of the NHS system. So if you and your colleagues are all working in the NHS as well as in the private system, and obviously the facilities are all shared, how does that manifest itself?
The bit we share is the delivery suite. In fact, we're going to have 2 dedicated rooms for us to use on the delivery suite. But at the moment, when we share the delivery suite, the mechanics of when you come in to a delivery suite is you'll be allocated a midwife. So whether you're public or private, you'll be allocated a midwife. You will also have a whole group of doctors looking after you if you're on the NHS. There's always a consultant, most of the time, on our delivery suite, along with a registrar and a junior grade doctor. If you were a private patient, you would have your own doctor, as well as access to all of those things. And now, does it ever happen that you're operating on a public patient and therefore couldn't make that leap into the next room? No, it's possible, but a caesarean section takes me 30, 40 minutes. So you'd have to be really unlucky. And with the numbers of people that we book, the clashes between the two shouldn't happen. Your point is really valid, however, that the time that you really want to be a private patient and have that quiet is afterwards. You've had the delivery, you're safe, the baby's safe, and then you want to go to an oasis of calm. And the problem with postnatal services in the NHS is that they're the least risky part of the whole obstetric process. The people who hit the postnatal ward, their babies are fine usually, and they're fine. And therefore staffing ratios are dreadful. If you think of a big public postnatal ward, there's about 30 to 40 beds, and therefore you've got at least 60 to 80 patients, because the baby's a patient as well. And the staffing ratios, the staff are put into the bits that you have to look after, the one-to-one midwifery during delivery, the antenatal care, the antenatal services. And it's the sort of the poor relation postnatal services. So the one thing that I think that works exceedingly well, and I think is far better in the obstetric world than the NHS, is postnatal care, where you'll have 2 or 3 people at St Thomas's looking after 5 or 6 patients at a maximum. So the help you'll get with breastfeeding, the support, all the lessons that you'll learn are just so much better, and you really feel looked after. And I think in the NHS, I think people do feel generally a little bit abandoned. They're not abandoned, because if you're sick, you'll get good care. But in terms of the touchy-feely care, it's not so good. We find that people will want to stay a lot longer if they've had a private baby, even though they're paying for it, because they're getting value. They really feel as if they're achieving something by being there. But that's the model I think that we wanted to access at Tommies. We wanted it to be safe. It's got to be safe, and I think the safety comes from being surrounded by all the high-tech things, and the high-tech things are on the NHS unit. It would take, for instance, I don't know, from a time that you're worried to getting into an operating theatre, a minute or at the very most, whereas if you were co-located, like maybe at one of the other sorts of models that people deliver on this separate private unit, to actually get to where the action happens for those people who need to get into an operating theatre, for instance, just takes longer. And actually, you don't always have a lot of time. We have rules of 3. So, for instance, I don't know if any of you have had a baby, but you'll often attach to a heart rate monitor if we want to watch the baby. And sometimes the heart rate drops. And within 3 minutes of the heart rate dropping, if it's stayed down there, you need to be doing something. And so the Thomases drop for 3 minutes. The next 3 minutes are getting into an operating theatre. And if the baby's not recovered, then the next 3 minutes are having an anaesthetic, and the baby should be out by the 12 minutes. And you can't achieve those things unless you've got wall-to-wall staff. And you've got to be safe.
Any more questions? Con, we'll leave it at that. Thank you so much for your time today.
You're very welcome. It's nice to meet you all.
Thank
Good
you.
luck.